this is another lovely teaching program we are having with our postgraduate team. We have a very senior person, he's our laparoscopic surgeon, and he's a VATS surgeon also, because he's a trained in respiratory diseases. And this is a case we are going to have. Dr. Singhla, you are a very celebrated person, and you have been working a lot of in lung surgeries. Now, what I could see, there is a big bulla here out there.
Yes, on the left.
This is a bulla which is progressive, and this kind of bulla normally we call the vanishing lung syndrome. Something the bulla can progress so badly that it can vanish the total lung. And if you see, this is an expanding bulla. Sir, you have done a great job. What I heard that you have done a bullectomy. So now over to you. What exactly you did in this bulla?
See, we have done a VATS, video-assisted thoracic surgery, through the fifth intercostal space, left fifth intercostal mid-axillary line. But the most important thing is it has to be on a double lumen tube, DLT, single lung ventilation.
So that means, sir,
the role of anesthetist is very, very important.
So that means role of anesthetist is very important. You have intubated one lung first.
No. It is a double lumen tube. With that we ventilate only one lung.
Okay. The other lung you block.
Block
it.
It's a double lumen tube.
So you learn that under the postgraduate, it's a double lumen tube.
It's called DLT.
DLT, double lumen tube, because he is going to work on one lung, because that is the left lung, na? So other lung will be ventilated.
Because once you deflate the affected side, the lung becomes of the size of the fist. Only the bulla remains. And then you mobilize the bulla, you puncture the bulla and endoloop the bulla. I have not used the stapler, because stapler costs 50,000 rupees. The loop costs 200 rupees.
Oh, wonderful.
So I have used.
So what I understand, what you have done with a double lumen tube, you have blocked the tube. The lung has gone into a deflation, or what you call absorption atelectasis. So you have totally removed the air from the lung.
Yes.
Then finally you entered the bulla mouth.
Yes.
With a tube.
You punctured.
We punctured
with a needle.
With a needle you have punctured. Then finally you have
then the whole bulla is mobilized. It was adherent at one or two places.
So
only.
you have done something like it's a marsupialization?
No.
It's not.
Complete bullectomy.
It's a complete bullectomy. So what you have done? So you have deflated the lung with a double lumen tube. Then you have punctured the bulla.
See, on the left side we use a left DLT. On the right side we use a right DLT. Okay. There are two types of DLT.
So here you have to do the
left.
Left DLT, because the disease is on the left side.
Yes.
Yeah.
So that we have two plugs. One is a tracheal block, other is a bronchial block. So in this we block the bronchi on the left side.
On the left side. Now
on
can
the
we see the post-operative? Your
post-op इसमें.
Just see the CT.
Only a little bit of pneumothorax is left. This is on day 2.
Just see what a great job has been done in our National Heart Institute. We'll do more this kind of surgeries. Wow. You see,
only the pneumothorax.
Just come and see and focus on this. You see this. Only a little pneumothorax is left. Come forward, tissue, and just see. This lung has expanded, and the bulla is gone. And it's a great job has been done, and only little pneumothorax is left, and patient is fine.
When I do an X-ray, I'll do a CT again. Then you will see the completely expanded lung. The bullectomy has been done.
So that means in a selected cases, one lung emphysematous bullectomy should be. If it is both the sides, then we should avoid it.
No, you can do both sides.
Both the sides.
Not in one sitting.
One sittings.
Second thing.
We had couple of patients with progressive bulla disease, so we can call them.
Always have to think how much volume reduction is possible. It's a question mark. How much volume reduction?
Once you have done the bullectomy, did this patient needs any kind of intervention, ventilation after that?
No. We remove the tube after half an hour.
That's wonderful. So that means.
And one thing, you have to remove tube early. You cannot put positive pressure ventilation on an endolooped bully, because that can blow out.
Okay.
Patient has to breathe at his own. If you pump it, then the healing, the loop can get dislodged.
So what you have to do, these residents, you have to go to the OT, ask for our chief anesthetist to show you DLT tubes.
Yes.
So
another thing is, you all being bronchoscopists, with a pediatric bronchoscope, it is very easy to use the DLT.
Okay.
Pass a pediatric bronchoscope through the DLT and position it. It's so easy.
You know, can we use feeding tubes also?
No.
Infant feeding
You
tube.
you can use a lighted fiber.
Lighted fiber. Because you
Can see it.
So we can use a pediatric, something like that.
Period 5 French. It has to be 5
Or something
French.
like, can we use a medical thoracoscope also?
No. It has to be in that respiratory passage.
Respiratory passage. Wonderful. Thank you, sir. Thanks for all
ये
your
रख के
good
देना
work.
वापस.
Okay.
ठीक है वापस.